morning, everyone. Welcome to Breakfast UMHealth live webinar series today on Wednesday, 30th April. Today, we would like to present Dr. Michelle Liew, one of our clinical lecturer orthopedic surgery from University Malaya, to talk about little hips, big impact, how on managing children with developmental dysplasia of the hip. Dr. Michelle, you can proceed.
So good morning, esteemed professors, consultants, and doctors. It is truly an honor to be given the opportunity to share with you the work we routinely do as the pediatric orthopedic surgery team at the University Malaya Medical Center. So my name is Michelle. I'm a clinical lecturer at the University Malaya and a recent addition to the pediatric orthopedic unit in the Department of Orthopedic Surgery. Our work is mostly centered around helping children with musculoskeletal conditions achieve a better quality of life while they're still young, despite the challenges posed by their underlying diseases and deformities. So among the many conditions we manage, one of the most common and impactful is developmental dysplasia of the hip, which I'm going to refer as DDH, and that will be the focus of this morning's breakfast talk. So what is developmental dysplasia of the hip? It is defined as an abnormality in the development of the acetabulum, resulting in a shallow and/or dysmorphic acetabular socket. It is a spectrum of structural abnormalities of the hip joint, ranging from subtle acetabular dysplasia with preserved joint congruency to subluxation of the femoral head where there is undercoverage of the femoral head to frank dislocation of the femoral head where it remains irreducible. So DDH is a dynamic condition which it can resolve over time or deteriorate as the child grows. So is it then accurate to diagnose a child with DDH based solely on the femoral head being displaced outside the acetabulum? No. So DDH is a diagnosis of exclusion. So it involves more than simply identifying a dislocated hip in children and calling it a DDH. It requires excluding other potential causes of dislocated hip like syndromic, neurological, or neuromuscular conditions such as cerebral palsy, teratogenic dislocation seen in Larsen syndrome, or arthrogryposis. And once primary pathologies have been ruled out, then the diagnosis of DDH can be established. So the components of the hip joint, namely the acetabulum and the femoral head, should be fully formed by the 11th week of intrauterine life. Acetabular development continues throughout intrauterine life, particularly by means of growth and development of the labrum. So in the normal hip at birth, the femoral head is deeply seated in and held within the acetabulum by the surface tension of the synovial fluid. The retaining force is similar to that of a suction cup. It is therefore extremely difficult to dislocate a normal infant's hip, even after you incise the hip joint capsule. So some may say newborns or young children's ligaments or capsules are normally lax. However, hips in newborns with DDH are not merely normal hips with capsular laxity. There is actual pathology in the hip. So the femoral head and the acetabulum mutually influences one another's growth and evolution starting from the perinatal period. So in a newborn with DDH, the tight fit between the femoral head and the acetabulum is lost. The femoral head can then glide in and out of the acetabulum, and it must be reduced as soon as possible, and the reduction must be maintained to provide the stimulus for acetabular development. If concentric reduction is maintained, the acetabulum has the potential for recovery and resumption of normal growth and development for many years. So the age at which a dysplastic hip can still return to normal after reduction remains controversial. So the kind of patients who present to us at our clinic represents a full spectrum of DDH. Some have an isolated dysplastic acetabulum, while others show a combined involvement of both the femoral and acetabulum region. So how do these patients actually find us? The newborns are typically referred following a positive Barlow and Ortolani test, that is a click felt during the maneuver, during routine screening by our pediatric medical team. So toddlers and young children often present with subluxation or frank dislocation, leading to limping gait, with or without limb length discrepancies, which all became noticeable when they started walking. So these were either due to misdiagnosis in the past or cases that were initially observed but have progressively worsened over time. So older children are usually referred to us either due to a recurrence following previous DDH treatment by us or outside, or as new cases identified by other healthcare centers or rehab or our pediatric team at our center, as patients became symptomatic either with pain at the hip or lower back because of compensation. So how do we respond to patients with DDH? So some clicks may actually be benign. So this is a result from the ligamentum teres intermittently catching between the femoral head and the acetabulum, which will resolve over time as the femoral head grows in size within the acetabulum and as the soft tissue becomes less lax with age. However, they may also suggest a dislocatable hip as seen in DDH. So to differentiate between these possibilities, we will need to carefully assess both the clinical history and the physical examination findings associated with DDH. So we routinely screen for perinatal risk factors such as primigravida status, oligohydramnios, breech presentation, and of the patient itself, patient being female, firstborn, macrosomic, or having a positive family history of DDH, whilst also examining for other packaging disorders such as a congenital muscular torticollis, metatarsus adductus, congenital knee dislocation. And as mentioned before, to rule out other primary pathology before concluding that this dislocated hip is actually a DDH. And then we finally determine whether is it a unilateral or bilateral presentation. So in our experience, the left hip is more commonly affected than the right. So what if in your examination there's no click? So is it not DDH then? So the Barlow and Ortolani tests are only valuable during the neonatal period, but they usually become negative by 3 months of age. So once the infant is more than 3 months, if the femoral head is subluxated or dislocated, the adductors and the flexor muscles gradually develop contractures. So the most common physical finding in older infants with DDH is limited abduction of the hip. Walking age children will present with limping, short limb gait, and limited hip abduction. So ultrasound is not cost-effective for routine screening of all infants. It is recommended though for infants or neonates in whom the physical examination of the hip is positive or equivocal, and for infants with risk factors for DDH. So we will usually arrange for a hip ultrasound if not already performed. In fact, ultrasound is the primary imaging modality from birth to 4 months old and most optimally performed when the infant is at least 4 to 6 weeks old to reduce the rate of false positive cases, which may be seen in the neonatal period because of physiologic immaturity of the hips. So the ultrasound offers many advantages over radiographs during these ages, as you can directly visualize bony acetabular anatomy, cartilaginous femoral head, labrum, ligamentum teres, hip capsules, which are all not shown on the radiograph. So results can actually show normal acetabular development even though the child demonstrates soft tissue clicks. So if a result suggestive of a subluxation or dislocation on the ultrasound, early initiation of treatment using the pelvic harness can be started to keep the femoral head within the acetabulum, and then performing the ultrasound again to reassess the hip if this has been achieved. If the child is more than 4 months, we usually perform radiographs instead. So usually we will order a pelvic x-ray as the femoral head would have been ossified between 4 to 6 months. In most cases, DDH is readily identifiable due to obvious subluxation or dislocation. However, in DDH, the femoral head is often smaller and in some cases so underdeveloped, making it less obvious on the radiograph. So this is when the radiographic parameters become essential for diagnosing and determining the severity of DDH. Essentially, there are 3 basic lines, and 1 angle measurement. First one being the Hilgerinus line, which is really the horizontal line through the right and left triradiate cartilage. The femoral head should be inferior to this line. And then the Perkins line, which is the perpendicular line to the Hilgerinus line. Basically, the femoral head should be medial to this perpendicular line. So once these 2 lines are drawn, the femoral head should sit in the lower inner quadrant, like so. So the Shenton's line is really the arc along the inferior border of the femoral neck and the superior margin of the obturator foramen, and the line should be continuous in a normal hip. In a DDH, it is most likely broken, like on the right. And delayed ossification of the femoral head is commonly seen in cases of DDH. Acetabular index is the angle formed between the Hilgerinus line and the line from a point on the lateral triradiate cartilage to a point on the lateral margins of the acetabulum. This angle should be less than 25 degrees in patients older than 6 months. How do you assess then if the DDH is very subtle on the plain radiograph. So this is when hip arthrogram is utilized. So commonly indicated in femoral head that's too small to be appreciated on the radiograph, or a patient with a acetabulum that demonstrates a high acetabular index. So arthrogram is usually performed on the patient in the operating theater under general anesthesia with fluoroscopy guidance. And it is usually not a standalone procedure. Usually you would have a plan either to like if the hips are reduced, then you would conservatively manage the patient with a cast or operative, which we will explore later. So it involves introducing a needle into the hip joint and then injecting radio-opaque dye into the joint and assessing under fluoroscopy guidance. So here it shows a primary subadductor approach to the placement of a needle in the left hip of a 7-year-old patient. So this is an arthrogram of the right hip showing a reduced right hip joint. So hip is considered congruent if the medial dipole is less than 5 millimeters on measurement, and this is normal. So if the pole is wider than this, the likelihood of a soft tissue blockage to reduction is high. The picture on the right shows the arrow pointing to a rose thorn sign, which indicates the free flap of a labrum in a normal hip joint. So again, why we perform a hip arthrogram in DDH, it's really to assess the hip joint congruency and stability, to identify possible soft tissue interposition, to confirm adequacy of your reduction, and finally to guide surgical decision-making if whether open reduction is required. So our management of DDH is usually individualized. It's based on the patient's age, the underlying causes, the sites involved, whether it's just the acetabulum or with or without the proximal femur being involved, or any prior treatments received thus far. We can divide it into the non-operative and the operative. So non-operative will include hip abduction brace. You can either choose a dynamic or rigid type. And of course, doing a close reduction of the hips and applying a hip spica. Operative usually involves open reduction with hip spica application, or performing a femoral osteotomy or a pelvic osteotomy, or a combination of pelvic and femoral osteotomy, and finally a pelvic support osteotomy. Hip arthroplasty is also one of the options for managing DDH. So in a non-operative management of DDH, so historically, double diapering was used as a simple method to promote the hip inflection and abduction in hope to keep the femoral head inside the acetabulum. And this was often recommended by pediatricians as an initial step while awaiting for imaging, such as ultrasound. However, current evidence in 2021 has shown that double diapering does not significantly alter hip position or prevent DDH. As a result, it is no longer considered an effective or recommended practice in modern DDH management. So a hip abduction brace of dynamic in nature is the pelvic harness. It is the first line of treatment for most infants under 6 months with established DDH as a diagnosis and whose hips are reducible. So it is actually effective in correcting all spectrums of DDH with success rate up to about 95%. As you can see, the pelvic harness allows for movement of the lower limbs while maintaining the hip in a specific position, which is a preferred way for managing younger infants. So the hips are usually able to be stabilized within 3 to 4 weeks of harness use, but we can continue this up to about 6 to 8 weeks, depending on the severity of DDH, and then performing a reassessment ultrasound to ensure the treatment is effective. So if stability is not achieved within this time frame, so there's a risk of developing pelvic harness disease, which is essentially a prolonged position of a dislocated hip in a flexion and abduction that potentiates a dysplasia, particularly at the posterolateral acetabulum. And then if this happens, it just increases the difficulty of obtaining a stable close reduction later on. So you should discontinue the harness treatment after 2 to 4 weeks if the hip remains unstable or dislocated to avoid this complication. Other complications whilst on the pelvic harness are femoral nerve palsy and avascular necrosis of the femoral head. So this table just illustrates that with increasing hip severity and instability, the more frequent the ultrasound reassessment needs to be to ensure the femoral head stays within the acetabulum during pelvic harness treatment. This reduces the risk of missing a dislocated hip and preventing a pelvic harness disease. So you can see the frequency can be as often as every 2 weeks. So this is a hip abduction brace in a more rigid manner. This is usually used for older infants or larger infants close to walking age in whom dynamic bracing is not possible, or those with a more severe kind of DDH, as it holds the hip in a fixed position using rigid support. It is also beneficial in unstable hips that have actually failed the dynamic brace. And then our next type of conservative management would be a close reduction and hip spica application. So these are usually indicated in neonates between 6 to 18 months and usually performed in the operating theatre, where we would do a close reduction of the hips inflection and abduction, check under fluoroscopy guidance for adequate coverage before applying a hip spica to maintain the hips in the most stable position. So the most stable position is normally called the safe zone or Ramsey, which is usually between 35 to 60 degrees of hip abduction. So let's just see a few cases we have managed. So we have patient A, who is a 6-month-old baby girl who was initially assessed by the pediatric team during follow-up visit at their clinic when she was about 5 months old. She was found to have limited abduction of the left hip, which is suspicious of left hip DDH, and was referred to us for further management. So as you can see, the pelvic radiograph, it appears that the left hip is sublux with a hypoplastic appearance of the femoral head. So after drawing the Hilgeriner and Perkins line, it shows that the femoral head it sits at the outer lower quadrant. So this confirms a DDH of the left hip. So you can see the acetabulum does appear comparable to the right side, but once the left hip acetabular index was measured, was found to be at 43 degrees, so indicating there is acetabular dysplasia. On the right side, so although the AI should be less than 25 in patients like 6 months and older, the right hip is still within the normal quadrant. So patient A underwent left hip arthrogram and close reduction and hip spica application. So we were able to reduce the femoral head into the acetabulum through close reduction and then confirming this with the intraoperative hip arthrogram. And the left hip was kept flexed at 100 degrees of flexion and abduction at 45 degrees, as this was the most stable position with good reduction. And we do the same as well for the right hip to emulate this position, so to enable the patient to sit comfortably in a stroller. So during hip spica application, we normally use a self-supporting spica frame, as you can see in the images, with an added suitcase support to aid in optimal patient positioning. So the child is carefully positioned in the frame, with suitcase supporting the upper torso and the hips positioned in approximately 90 degrees of flexion and 50 degrees of abduction, replicating the desired reduction position. So under fluoroscopic guidance, we confirm that the femoral head is adequately reduced within the acetabulum prior to applying the cast. So while plaster of Paris is a commonly used material at UMMC, we prefer a delta dry padding combined with fiberglass. So this combination offers a lighter, more durable alternative, which is particularly advantageous given the need for the spica to be in place for approximately 12 weeks. So at UMMC, we have also adapted and refined the original hip spica application technique first described by Kumar in 1981 by developing a modified approach as illustrated in the image in 2016. So in our new technique, we utilize just 3 strategically placed slabs as opposed to the 14 slabs in the original method. And we were still able to achieve a structurally stronger cast than those applied using the Kumar method. So what usually happens after hip spica application is that we will keep it for about 6 weeks. We will advise the parents on perineal hygiene and to come back as soon as possible if they get soiled for some reason. And then if needed to be changed or if at the end of 6 weeks, we will normally change it anyways. We'll do it in the OT under general anesthesia and then continue the hip spica for another 6 weeks and subsequently remove in the daycare OT. And then put the patient on the rigid abduction brace for about a year. So what if the hip is not reducible? So this is when the intraoperative assessment using the arthrogram is helpful to determine if open reduction is necessary to ensure successful reduction. So in the image on the left hip arthrogram shows the right hip of a 4-month-old patient before open reduction of DDH. So when the head was docked, you can see that the labrum was interposed between the femoral head and the acetabular wall. Because of the capsular constriction of the iliac psoas, stable reduction was not possible. So on the right is the intraoperative arthrogram of a hip belonging to a 4-year-old patient with delayed diagnosis of DDH. And you can appreciate a large medial dipole indicated by the white arrow. it seems to be more than 5 millimeters. And then there's an intern labrum at the superior portion of the shallow acetabulum as well, indicated by the red arrow. So if these were left as such and immobilized in a hip spica, most likely the hips will dislocate back to where they were before once the hip spica is removed. Therefore, open reduction is necessary to assess and confirm structural blockages, during which they can also be removed for successful reduction. So these are possible blockages to reductions in the DDH. You can divide them into the intra-articular or extra-articular components. So if blockages are suspected during closed reduction and hip arthrogram, an open reduction of the hip joint is therefore necessary. So for the open reduction of the hip, it's usually performed using the anterior approach. So we prefer a bikini skin incision followed by Smith-Patterson approach to access the hip joint. So the incision is made along the groin crease and it measures about 2.5 centimeters in length. The resulting scar is often barely visible after a few years, as you can see in the image. Okay, so pelvic osteotomies, another type of procedure that we commonly do, sometimes during the setting of an open reduction. So we can actually group them into various ways, and this is just one way to categorize them based on what changes are made to the acetabulum, whether you're performing a redirectional, reshaping, or salvage. So at UMMC, we typically perform Salter and triples for a redirectional osteotomy. A reshaping, we would normally opt for a Degar. So yeah, again, the type of pelvic osteotomy chosen is based on where the acetabular roof deficiency is. So DDH is usually an anterolateral deficiency. That is why we often utilize Salter or steel triples, a redirectional osteotomy for skeletally immature bones. A Degar, which is a reshaping osteotomy, addresses a posterior deficiency. And Chiari involves shifting the acetabulum medially to improve the coverage of the femoral head. So the unmoved superior portion usually blocks the proximal head migration. So let's see an example of how we have done a Salter osteotomy for a patient who is a 1-year, 6-month-old girl who was referred to us for short limb gait of the left lower limb. So pelvic radiograph noted a frank dislocation of the left femoral head. She underwent left hip arthrogram, which demonstrated structural blockages, hence an open reduction was necessary. Salter osteotomy for the pelvis and adductor release and hip spica was performed as well. So following the procedures, you can appreciate the improvement in the acetabular index from 39.8 degrees to 17.6 degrees. And you can appreciate as well a well-seated left femoral head within the acetabulum following the surgery. So some patients may require additional procedures to the femur, such as this patient who was nearly 1 year, 11 months old when DDH was diagnosed. So patient has an underlying Pierre-Robin syndrome with multiple episodes of upper airway obstruction requiring tracheostomy. So her DDH was actually picked up by our pediatric rehabilitation team due to limb length discrepancy of 2 centimeters and then referred to us. However, we could only manage her operatively 10 months later at 2 years, 9 months, once her airways were assessed and stabilized by ENT. So by then, you can see that her right hip dislocation had migrated further proximally at 2 years, 9 months. The AI was about 36.2 degrees. So she underwent right hip open reduction. Salter osteotomy had done also a femoral shortening with adductor tenotomy and hip spica. So the femoral shortening had to be performed as the femoral head was high riding, and if it's forced down into reduction, the high tension forces of the hip reduction can increase the pressure on the femoral head, potentially causing an avascular necrosis of the femoral head. So this is her radiograph at 4 years old. It shows how much we have obtained, how much coverage we have obtained for the right hip. So femoral osteotomies are performed to facilitate reduction, to reduce the risk of avascular necrosis of the femoral head by relieving tension produced by reduction of a previously dislocated hip, to correct excessive femoral anteversion, which we would then call a derotational osteotomy, to correct a high neck shaft angle, which we would then call a varus osteotomy. So there are various types of varus, derotational, and shortening of the femur. So the picture on the left shows how a piece of a wedge shaped bone is cut from the proximal femur to create a varus proximal femur, so the femoral head seat can seat deeply within the acetabulum. But nowadays, we use a pediatric hip plate, such as the image with 110 degrees medialization angle to create this varus deformity of the proximal femur. So femoral osteotomies can actually be combined, and if done, it is usually called a femoral varus derotational osteotomy. So remember the patient B, whom we have done the Salter osteotomy for previously. So as we continue to follow up with her on a 6-monthly basis with repeated pelvic radiographs, we noted that the left hip appeared subluxated, though very subtle. So a femoral varus derotational osteotomy was performed to keep the femoral head within the acetabulum, and so we actually made the proximal femur in a varus angle to ensure the head sits within the acetabulum. So as the patient is 4 years and 7 months, it was essential to intervene at this juncture to prevent further subluxation and subsequent dislocation of the left hip as she grows. So what about in cases of bilateral DDH? Which one do we address first? So do you address both or one side first followed by the other? So it certainly makes sense to treat both at the same time so that when patient starts to walk, she can do so efficiently and to reduce the total number of days she misses out in school due to recovery and the rehab. So this is one of our patients who was referred to us at day 1 of life following a positive Barlow and Ortolani test for bilateral hips. So she was subsequently treated with pelvic harness, about 1 month old, but both hips remain dislocated as seen in this pelvic radiograph at 5 months of age. So the team waited for her to be slightly older, about 6 months of age, for close reduction, bilateral hip arthrogram, and hip spica. So during the change of hip spica, it was noted that the left hip is unstable whilst the right hip remains stable. Both hips were actually placed at the angle of best stability and continued on the hip spica for another 6 weeks. However, after removal of the first hip spica applied, we noted that both hips dislocated again, so indicating both hips are actually unstable. So we then scheduled her for another close reduction of bilateral hips and hip spica. So during the intraoperative assessment with an arthrogram, we were able to get adequate reduction of both hips. So the left hip reduction was maintained, and you can see that subsequently when we removed the hip spica, the left hip remodeled well, and the hip was in the joint. But unfortunately, the right hip remained dislocated. So what we can appreciate throughout her years of growing up is that there's a remodeling ability of the left hip over time. But because the right hip remained dislocated after multiple attempts of reduction, we had then sent her for evaluation by the genetics team to rule out any underlying neuromuscular condition that could have contributed to her recalcitrant right hip. So only once this is ruled out, then we proceeded with intervening the right hip. So then COVID happened, and then a lot of elective cases had to be put on hold, including hers. So she finally only underwent an open reduction and femoral shortening with Salter osteotomy and hip spica at 2 years, 7 months old. So as you can see, we were able to bring the femoral head down and inside the acetabulum whilst using a Salter osteotomy to increase the acetabular coverage. And by 4 years old, her right hip has remodeled well with containment of the right femoral head within the right acetabulum. However, then we noticed the left hip demonstrated shallow acetabulum with high acetabular index. But because the pelvic radiograph looks a bit rotated, we continued observation. We repeated radiographs at the next visit. So the patient actually remained asymptomatic at both hips after both hips have been reduced and remodeled with comparable hip range of motions. However, given her past history and subtle subluxation of the left femoral head with high AI, our team decided that she would require or would benefit from a Degas osteotomy of the left acetabulum to improve the coverage over the left femoral head. So So we've used a piece of bone, which we have gotten from her iliac crest, to insert at the osteotomy site. So as you can appreciate, after the Degas osteotomy, there is more coverage on the left hip, left femoral head. So the next type of procedure that we could offer to patients would be a pelvic support osteotomy in cases of neglected DDH. So why neglected DDH again? So it normally occurs in patients who were unable or whose parents were unwilling to seek appropriate medical treatment when the patient was younger, despite patient limping. Sometimes neglected DDH can occur when parents lack sufficient knowledge to actually detect the problem in their children. Because DDH often presents as a painless limb as well. So by the time the child who is now in their late teens present to clinic, they complain of pain at the hip or even the lower back. So thus restricting their range of motion, especially hip abduction or having difficulty walking where they get easily fatigued in their mobilization. So yeah, so essentially it's a salvage procedure for cases of neglected DDH. So what exactly is a PSO, a pelvic support osteotomy? Is a salvage procedure and it's a double level femoral osteotomy. That is, there is only two cuts made along the femoral shaft, which is then manipulated. You have the proximal cut, which lateralizes and displaces the greater trochanter of the femur to increase the abduction muscle function. And then you have a more distal cut to restore the mechanical axis of the limb. And if there is limb length discrepancy or like a shortening, you can do lengthening at that area. So take note that actually the femoral head is left out of the acetabulum. So as you can appreciate from this image here, the femoral head is actually left out of the acetabulum. You don't try to reduce it back to the acetabulum. And then two osteotomy sites are made along the femur to manipulate. So what this achieves is that you would be able to eliminate a Trendelenburg gait. You can equalize a limb length discrepancy. You can provide stability to the hemipelvis, all of which in hope to give rise to a more energy efficient gait to the patient. So this is an example of a PSO we had performed on a 15-year-old female patient with neglected DDH for about 10 years. So 10 years ago, she was noted to have a limb length discrepancy of about, can't remember the exact amount, but yeah, at that time when we counseled the patient for like a reduction in a Salter osteotomy, the parents were not very keen for surgical intervention. And finally, she presented to us at 15 years old with increasing difficulty in walking because of her left hip pain and with more noticeable limping. So as you can see, we left the hips outside at where it was all this while and made the two cuts along the femur. And then we applied a monorail fixator with pins to stabilize the cuts made. And lengthening was performed subsequently, as can be appreciated by the increasing gaps at the second osteotomy site. So external fixators usually hold the osteotomy sites in place. It can be the circumferential type, which we call a multiplanar, or it can be a monorail, which is a uniplanar type. So we prefer the uniplanar construct as it is lighter and non-obstructing for the patient. So the whole external fixators were kept for our patient for a total of 9 months until the osteotomy sites demonstrate bone union radiologically. So overall, we were able to improve her abduction to about 13 degrees more than before, and she had very minimal left hip pain after the surgery, not as often as before. And we were also able to equalize both limbs and reduced her Trendelenburg gait. So in summary, for DDH this morning, refer early to the pediatric orthopedic team if a patient is suspected to have DDH. You could order an ultrasound of the suspected hip. So early diagnosis enables earlier intervention, minimizing delays in their gross motor development. Early intervention also reduces the need for more extensive procedures later on. So we normally closely follow up our patients until they reach skeletal maturity. And sometimes we still see them when they have also reached the early adult age as well, because recurrence can actually occur. So these are my references. Yeah, so if you have any further questions about the topic, I guess you can ask some questions after this. Otherwise, you could email me as well. So thank you.
Okay, thank you, Dr. Michelle, for your excellent talk. There are a few questions actually in the Q&A session box. The first one we'll begin with is with Prof. Sarah. She says it's a nice talk, thank you. May I ask, in the child with Pierre-Robin syndrome, did the child end up with limb length discrepancy?
That would have been patient
I think it's B or C, if you're not
oh
mistaken.
yep, sorry, I
Yeah.
Should I share my slides again? Yes, so this patient, yes, has a limb length discrepancy of about 2 centimeter
Initially or after?
when it was picked up by our pediatric team.
Mm.
Yeah.
And subsequently after the surgery?
Subsequently, after surgery, we were able to get comparable limb length as the unaffected side.
Okay. Yeah, I believe because the Salter gives another additional 1 centimeter when you reduce it. Okay. The next question, does the child's ambulation ability, whether it's walking, delayed walking or doesn't walk, will it affect the decision for again or against the surgery?
I think it would. So if in a non-walker child, for example, maybe the child has underlying conditions that would then preclude their ability to walk in the future, we would try to reduce the try to reduce the femoral head into the acetabulum. But whether or not the child gets a comparable limb length with unaffected side, I think we will not focus on that. I think the main thing is really to get the femoral head in the acetabulum so that in hope that the hip joint remodels as the child grows. And then we would still observe because the child probably would have been quite young in age to determine their walking abilities. So we'll still monitor for hip remodeling.
Okay, I agree with you actually. And also for at least for sitting purposes, they're a bit more comfortable with the hips reduced. Okay, you told in your conclusion that early, this is my question actually, early referral to the pediatric orthopedic team is important. Can you just enlighten the crowd, what are the factors, the risk factors they need to be aware of so that they can early refer these patients to us for earlier screening so that we can intervene much earlier?
All right. So usually when so a Barlow and Ortolani's test is really performed by our pediatric team or even our ONG team sometimes. So once a click is suspected in that maneuver, yes, you would refer to the orthopedics team because sometimes our appointment dates are not very I mean it's not sometimes not 1 week later. So then you could order an ultrasound, but make sure it's done like at least 4 weeks, not too early. And also just exploring the risk factors of the pregnancy as well, being mom being a primary gravida, there is oligohydramnios, the child being a firstborn female. So these are the risk factors that of the child and of the pregnancy as well that you would then highly suspect that, hey, maybe this is DDH, especially with a positive Barlow and Ortolani's test.
Okay. The other thing is, okay, a little bit more extra, for those young babies is that, swaddling is not a good idea because we have noticed that along the way, those like Native Americans and all that, due to their swaddling of their babies at the early childhood, it tends up to end up to have a dislocation of the hips. So we do not encourage patients to swaddle their kids because especially with those with risk factors to prevent from DDH from happening. So the question that we would like to also ask is that do we have a referral protocol for hip screening in PPUM?
Uh, I'm not aware of one, but I hope we do.
Okay, yeah. We do have a sort of a referral protocols where we those with patients with risk factors, as you mentioned, with either they are female or first child with a breech position or any fetal abnormalities with hydromenos, sorry. Those are patients that we actually accept them for hip screening because we know that these patients eventually they do either have a hip dislocation or either a hip dysplasia that we need to catch at an early age because this hip dysplasia can be silently present until their later onset and they end up with having hip arthritis. So we do actually encourage to people, pediatrics or ONGs to actually refer us for hip screening. You can actually refer to us and we will should see them within 2 weeks after their delivery of the child. I guess there's no more further questions from the crowd. Wait, oh, sorry, is there any more? Mm, Okay. Yeah, there's one more question. What kind of challenges do you face in counseling parents about the prognosis of post-surgery?
I think as we have seen in some of the cases presented, recurrence can occur. Patient needs to be actually followed up on a frequent basis with repeated radiographs. So I think it's really to explain the potential sequelae of even after treatment to the patients requiring serial radiographs. I think parents would often be concerned about the X-ray exposure, and then having to come every 6 monthly, and the fact that it can also recur. I think it's really to set the expectations from the start. So sometimes it's a little bit difficult because we all think that once you do surgery, you will solve the matter. But in this case, things can actually recur. So I think that would be a challenge, or at least what I've observed so far.
If there isn't, then I think we can end our session here today. I believe there's no second session of this Health for today. So we will end our breakfast now. Thank you so much for everyone who's attending. We will see you in the following breakfast web series.